Deconstructed, Mental Health and Wellness with Dr. Kaz and George.
The statements of Dr. Kaz and George are not a substitute for medical care, and our opinions are our own. If you are experiencing a mental health emergency, please seek assistance from a professional in your area.
You can contact us via Twitter at MindDeconstruct. I'm your host, George. With me is Dr. Kaz. Dr. Kaz Nelson is an American Board of Psychiatry and Neurology certified psychiatrist, licensed to practice medicine in the state of Minnesota, and an assistant professor in the Department of Psychiatry at the University of Minnesota Medical School. On today's episode, the revolution of borderline personality disorder. Dr. Kaz, I know you're a big advocate for borderline personality disorder. Are you excited to finally get a chance to talk about it today?
Yes, I've been waiting for a while. I'm really passionate about this. Before we get to that, I just wanted to check in with the podcast audience, let you know that we're having a lot of fun putting this together. Hope you find this as a useful resource. And once again, just wanted to summarize the goal of this podcast is to kind of take something that's mysterious, something that people go to medical school for a long time to understand, the field of psychiatry, and to translate it into plain language and understandable concepts so that you have a framework for understanding these things, which can be sometimes complicated.
As someone who's not a medical professional over here on this side, I'm having a good time talking about these mental health topics and learning from Dr. Kaz, so I hope our audience is too. Today, we're going to start off by some hot topics in mental health. The GAP conference. What is GAP, Dr. Kaz?
Yes, it's the Global Alliance for Prevention and Early Intervention for Borderline Personality Disorder, and this conference took place about a week ago, September 16th, in Atlanta, Georgia.
Did you go to the GAP conference this year?
I was not at the GAP conference, but I followed the agenda closely and was very excited about this since it's a lot of different advocacy organizations for borderline personality disorder getting together for one day to discuss strategies for prevention and early intervention.
One day, is that enough time to talk about borderline personality disorder?
I have talked about borderline personality disorder for a whole day, and I could talk about it for days and days and days because it's such an under-discussed disorder that it impacts so many people, so we really got to get the word out.
Is it all right if for the rest of the episode we say BPD a little bit?
Yeah, let's use that. BPD. That's kind of a common acronym for that.
Okay, so last time I'm going to say it. Dr. Kaz, what is borderline personality disorder, or BPD?
Well, it's in a group of disorders called personality disorders. Now, as we've discussed on the podcast before, the way these things are written down and the criteria, it's sort of a best guess at this point, and this is one of those disorders where the current best guess and how it's classified might not be completely accurate. So there's a lot of discussion about what that's going to look like in our diagnostic and statistical manual, but I can tell you how it's classified at the moment.
How could we help someone relate to what a personality disorder is as opposed to what depression is and maybe what schizophrenia is, that some of the things we've already talked about a little bit?
Yeah. So the field of psychiatry and psychology came up with a group of disorders that they considered to be sort of different from things like schizophrenia and depression, where somebody might be going along and have a depression episode or something like that, but it wasn't necessarily related to their day-to-day life and kind of what makes them tick. Personality disorders, they thought were more subtle, more related to your personality traits, not changing, present in basically, whether you're at school or work or with your family, these traits would be present in those settings, and they would cause a lot of problems, cause functional impairment and distress.
Are they kind of a newer disorder in terms of diagnoses?
Well, yeah, I would say some of the things like schizophrenia and major depression kind of came first, and then as people were getting a little bit better and more clear about how to classify disorders, it was this group of personality disorders were proposed. And there's about 9 or 10 different personality disorders.
Okay, so we won't go through those today. So what specifically is BPD in that family of larger personality disorders?
Yeah, so the way it's been proposed is that BPD is a personality disorder where somebody might have different personality traits that really impact them in a difficult and painful way. So some of those symptoms or traits that somebody might have include things like avoiding abandonment, working, in fact, working very, very hard to avoid abandonment. Like if somebody were to even say, goodbye, I'm going to go to the store, the person might say, no, don't leave me. That, nobody likes to be abandoned, but it would be a real high sensitivity to sort of being left or abandoned. Unstable relationships, problems with their knowing themselves or knowing their identity, impulsive behaviors like spending money or having sex with people they normally wouldn't have sex with, that kind of thing. Recurrent suicidal behavior, mood swings that go all over the place from minute to minute, depending on their circumstances, feelings of emptiness, periods of intense anger. And then at times they can even have what look like psychotic symptoms where they get very paranoid or worried that people are out to cause them harm.
Now, a lot of those symptoms sound very much like someone may have one or two of those symptoms, and some of those symptoms may also be included in, say, depression or
anxiety
or
yes,
maybe agoraphobia. I'm not sure. But is it hard to diagnose BPD then?
yes, because there's so much symptom overlap with other things, and because in order to meet criteria for borderline personality disorder, you would have at least five of these 9 symptoms. It's what we call a very heterogeneous or very, one person with BPD might look very different than another person with BPD. So that's where the confusion comes in.
So what have we learned in recent decades, if that's what we're working with right now?
Yes. Well, we've learned that BPD is very different from other personality disorders. So what makes it different is with other personality disorders, they tend to, people might meet criteria for that personality disorder, but not particularly be bothered by it too much themselves. It might be something more that other people notice. But with BPD, there's a lot of distress associated with it, a lot of going to doctors or going to psychiatrists or psychologists saying, help me, something's wrong. It's really not consistent with their goals or how they want to be. It's something that they don't feel that they're able to control. And so that's one of the reasons why it's kind of set apart in some ways. And so because it's different than the other personality disorders, it's really been studied a lot, and we've learned some very key things in the last couple decades.
Getting back to it, so what have we learned then?
Yes. So we've learned that it's very serious because people with this can die. There's a high rate of suicide attempt and a high rate of suicide with this disorder. So we've really learned how serious it is.
What else?
We've learned actually that when they've studied people over time with borderline personality disorder, even severe cases, that it tends to get better over time if the person survives and doesn't take their life, that over time people tend to not meet as many criteria of borderline personality disorder. In fact,
it gets better over time. Does it get worse again? Can it come back?
Yeah, so when they study people over time, there are some episodes where people might be under particular stress where they can have some of the symptoms come back again. But in general, people tend to develop out of the symptoms over decades.
So minus the suicide risk, is it something someone can just wait out?
Well, the idea is that it gets better over time, but it might take 10 or 20 or 30 years. And in those 10 or 20 or 30 years, life might be very difficult and painful while these symptoms are still going on. So we really want to get people appropriate treatment so they don't have to wait it out.
Yeah, probably better to treat that. How about men versus women?
Well, there's a stereotype in the medical field that this is a disorder of women. But when they actually go and look out in community samples and assess people for this disorder, they find that it actually impacts men and women equally. What my concern is that maybe women might be more disabled by this disorder or more willing to seek help for it. And that's why there's this stereotype that it's a disorder of women. And I think there's a lot of men involved in the criminal justice system who have this disorder, unfortunately.
Is this something that a doctor back in the 50s might have called hysteria or like fragility or something sexist?
Yes, there's this unfortunate and potentially inappropriate and woven into history kind of association with this disorder. The other thing to understand about this disorder is that it's common. It impacts anywhere from 2 to 6% of the population. So chances are you know somebody with BPD. And the other really awesome, notable thing that we learned is that it's inheritable. So if it might be something that runs in families or something that has a biological or genetic underpinning.
2 to 6%, that's pretty impressive.
It's a lot of people.
Those are pretty good odds.
Yeah. It's more common than other psychiatric disorders, but we don't talk about this as much as we talk about other psychiatric disorders, which makes that really sad.
What is going on in the brain of a person with BPD then?
Well, we've been studying this very closely. There's a lot of really good neuroimaging work going on, both neuroimaging that kind of looks at the structure of the brain and also neuroimaging that looks at the functioning of the brain. And what's been theorized is that people with borderline personality disorder, when they have to deal with interpersonal interactions, dealing with other people or human beings, they are using their parts of their brain that react when they're under threat. So we have this wiring in our brain that helps us respond to threats that cause us to fight or flee or freeze.
Commonly called fight or flight.
Yes, but don't forget about freeze, because that's important too. That's the third thing that animals
I've never heard that one.
Yes, that's something that animals or people do when they're under threat. One of those three things. And imagine what it'd be like if every time you were dealing with people, you were processing those interactions using that threat center of your brain rather than the other parts of your brain. You end up with a lot of those symptoms on the list. And if we went back and visited that criteria that I talked about, avoidance of abandonment, unstable relationships, having trouble understanding yourself, these reactive mood swings, feelings of emptiness or intense anger, all of those are threat phenomena. And when people have this come up for them day in and day out and dealing with people, it's completely exhausting.
Is that like you ask them what kind of sandwich they want and they, throw a plate at your head, or what?
I mean, yeah, that's one way it could manifest. Another way would be, if you're trying to make friends, you'd maybe try to test out if this friend is going to be a threat or a safe person. And if they're a threat, you might push them away. Or if they're a safe person, you might say, okay, you're on my team, and kind of call them, 50 times a day, to a point where they say, oh, this is too many phone calls. And then they might actually leave that friendship. And then, there can be kind of this pattern that goes over and over because, some of these interpersonal issues can actually cause somebody with BPD to be abandoned as a friend. It's a very painful cycle.
Yeah, it doesn't seem like it'd be easy to get along with a person having those sorts of symptoms.
No, it causes a lot of dysfunction in families and job environment and in personal relationships. But the person most impacted is actually the person with the disorder. It's very, very excruciating to live in a world this way.
How is it treated then?
Well, it's been amazing that over the years we've developed treatments for this that actually work. I got to tell you, it has a reputation of being an untreatable disorder. And some of the new treatments that are actually making an impact on this are causing us to question actually what we think about BPD. And there's a lot of discussion that maybe this isn't actually a personality disorder if these types of patterns and behaviors get better with treatment. And so in episode 2, where I talked about talking therapy or psychotherapy, one of the therapies I discussed was dialectical behavior therapy. That's an evidence-based psychotherapy treatment for borderline personality disorder. There are other ones too that have been studied. Mentalization-based therapy is one of them. And these therapies have been shown to have an impact on these brain patterns so that somebody can use their whole brain when interacting with people, not just those threat centers.
Are there any medications available?
Well, there are no FDA-approved medications for the treatment of BPD. So anytime medications are used, it would be considered in an off-label kind of way. But there have been studies of certain classes of medications, and there are some medications that can help somebody function a little bit better or help somebody develop skills over time by helping their brain system work a little bit better. And so working with a BPD-informed psychiatrist or prescriber is really important, because what sometimes happens is, because these symptoms are so difficult and span a wide range of symptoms, sometimes people end up on 6, 7, 8, 9, 10 medicines to try to help, and there's really no data supporting that approach.
These aren't the sort of things that you should be going to your family practitioner trying to figure this out.
There may be some family medicine doctors who have done some additional training to understand this pattern and understand best practices and approaches for BPD. So I don't want to sell the field short, because there's some wonderful family medicine or internal medicine physicians partnering to meet the needs of people with mental health conditions. But I would say that if there's significant self-injury or suicidality as part of it, it may be worth going to a specialist to help sort through that.
Interesting. Is there a personality disorder specialty like we talked about in the first episode, or is it more just someone who considers themselves or, understands BPD and the treatments available?
I think that any physician who's aware of the diagnosis and can talk about the criteria and can offer some accepted treatments would probably fit the bill. Where I get concerned is if there are people who don't want to acknowledge that there's such thing as BPD, or have trouble saying the name out loud or trouble talking about it. That might not be somebody who's poised to really address those specific symptoms.
Well, that kind of segues nicely into talking about Chuck. Now, Chuck is a gentleman that I've never met, and I don't think you've probably...
Not in person, no.
Okay, but you've communicated with Chuck, and Chuck is living with BPD.
Yes.
And he's someone that... who, in reading what we have as his essay here, he seems to be a person who definitely understands what's going on in his own life at this point in time, although the essay kind of outlines that he didn't always understand what was going on in his life, and kind of those things you talked about, those symptoms that he couldn't really figure out for a long period of time. Now, we do have an essay by Chuck that we're going to put a link to on our webpage. That's theminddeconstructed.libsyn.com. You can also listen to all of our podcast episodes on that page. And I think, Dr. Kaz, do you want to talk a little bit more about Chuck and his kind of journey and how it's outlined in that essay?
Yeah, this was a story that just completely broke my heart. But believe me, I've heard stories similar to Chuck hundreds and hundreds of times. I was actually giving a talk at the University of Minnesota, and some very wonderful people came up to me after the talk and said, I heard you talk about borderline personality disorder. I heard you talk about its treatment, and we're concerned that we have a dear friend who maybe has this condition. And I let them know, that was okay to talk about with their friend. It's kind of a weird sounding diagnosis, and so it doesn't necessarily, sound like a fun thing to be diagnosed with. But they were courageous and followed up with their friend and actually said, I think you have borderline personality disorder. And Chuck went ahead and looked up the criteria online and did a little self-educating on the topic, and immediately knew that this was what he was struggling with. But what really baffled him is that he had had interactions with therapists and psychiatrists over the years, because he'd been struggling significantly with these mental health symptoms, and nobody had ever brought up this term with him before. They, of course, had talked about depression or anxiety or bipolarity or any of these kinds of things. And the puzzle pieces never really fit for him, and he had a lot of trouble improving, and in fact had a lot of damage to his personal relationships and his career related to his symptoms. And as soon as he found out what it was, he sought treatment for borderline personality disorder, had a significant improvement, and is feeling like he had always wished to after a couple years of treatment. So it's really both a sad and quite an inspiring story that we wanted to share with you.
Now, in his essay, he talks about how when he confronted his therapist at the time and said, hey, I think I have BPD, and my friends said I had BPD, or believe I have BPD, the therapist said, well, yeah, they're right.
Yeah.
And he goes through a few reasons why that therapist may not have told him, or all of his other therapists may not have told him when he suspects that maybe they knew that. Is that common that someone may have BPD and be in some sort of treatment but not be told that they have BPD?
Yeah, and that's kind of the historical basis of the disorder. There was a certain wisdom in not telling somebody that they had BPD. And part of that, I believe, really came from compassion, because for a while it was believed to be untreatable and unchangeable. And I really believe that there are a lot of mental health providers out there who have faith in human beings and faith in their recovery and hate the idea of labeling somebody with something that's intrinsic and unchangeable and somewhat pejorative and very stigmatized at this point. And so I can certainly see that point of view, but it's based on something that's not accurate. The truth is, this is treatable. That education alone about the symptoms and what causes it actually leads to symptom improvement because people can understand it and better manage. I mean, imagine, George, if you had diabetes and the doctor was, feeling too bad about that diagnosis to tell you it.
Yeah, he said, take your blood sugar every day and maybe take this insulin, but not tell me why.
Right.
That would be scary.
Not to give you a name of it, and not, that kind of robs you from the opportunity to learn about it and to know how to manage it for you.
Yeah, I wouldn't be able to educate myself or learn or get past a certain point. I would only know that I need to take my blood sugar, and maybe I wouldn't want to do that one day, and I'd just shrug it off, and then, who knows what would happen.
Exactly. I mean, I think that's, an apt analogy. And so there's a lot of discussion in the field right now and a lot of training going on of people going through training now on best practices in identifying this and actually having a conversation with the patient about the history of this disorder, that it's got this weird name. Maybe we'll come up with a better name like emotional dysregulation disorder or something like that, something that doesn't imply that it's not changeable, because it's probably a developmentally based mood disorder, and we can have a whole other podcast on why somebody might develop borderline personality disorder. Let's put that on the list. But there's actually a hopeful outcome if people can get it appropriately treated.
And appropriate treatment is what Chuck talks about, DBT and cognitive behavioral therapy, and something called EMDR that maybe we'll talk about at some point, and then just practice, which looks like just kind of, going through all those things and internalizing them. Are those the prescribed treatments?
Yeah. It looked like Chuck got some really good treatment at that point. And basically it's any kind of treatment that helps somebody shift mentally from the threat centers of their brain to using other parts of the brain. And that's easier said than done and requires a lot of practice, because there's whole neural networks and pathways that need to be reshaped when you have BPD. And it's kind of like if you're walking through the jungle with a machete and you're cutting vines and leaves in front of you. It's really hard to do the first time, but as you practice and keep going down that path, pretty soon those neurons become a superhighway to facilitate your functioning without trying too hard at some point. So the recovery from BPD is not easy, but it's completely possible, and it goes even better if you have good support.
Who should someone contact if they believe that they may have BPD? Maybe after listening to this podcast, or if someone listening to this podcast, then talks to their friend. Where should they go next?
There are some wonderful advocacy organizations that you can check out online. One of them is the National Education Alliance on Borderline Personality Disorder, and they have a wonderful website with diagnosis or with resources for if you think you might have BPD or you think a loved one has BPD. They actually run these courses called Family Connections that help support family members and train them in how to compassionately engage with a loved one with BPD. The National Alliance on Mental Illness has a lot of resources, and the one in Minnesota runs Family Connections groups, so that's a wonderful resource. And there's always the medical community, your primary care provider or your psychiatrist, or setting up an appointment to discuss this with a psychotherapist.
Now we got so excited there. We kind of blew through our third segment of the questions. We kind of already talked about. We were going to talk about Chuck's questions, a couple of questions he had from his essay, and we kind of covered those. BPD is a misnomer. Chuck says it's a misnomer, and you kind of already talked about that a little. Borderline personality disorder. I don't know why it's called borderline.
Yes. Chuck titled his essay "My Shameful Diagnosis," and that just cut straight to my heart because people with BPD already feel so much shame. Why do we need to encumber them with more shame and a stigmatized diagnosis? So there's a lot of debate on this topic, but basically the term borderline came from the idea that back in the mid-1900s, people would come in the office and kind of look like they had what was called a neurotic disorder, like a problem with depression and anxiety, but under stress, they would almost look like they had a psychotic disorder, like schizophrenia. And so this term borderline came about because it was on the, quote, borderline of psychoses and neuroses. And so it's a term that's a little bit historical, and we're trying to come together as a field to know what to do with that.
What would your name be for the disorder?
There are a lot of advocacy groups who have come forward with different names. The one that I tend to go to is something like emotional dysregulation disorder or pervasive emotional dysregulation, something like that.
Can we call it triple F?
What's that?
Fight, flight, or freeze?
Does that make fight, flight, or freeze when you're dealing with people. Triple F for P.
Okay, maybe that doesn't work.
That might, in the focus group, that might get tossed out.
Probably. Thank you for joining us today. This podcast was produced by Kaz and George. Music by Paul.
He's the best.
Contact us and send us your questions on Twitter at MindDeconstruct.